What if the itch, the one you've been treating with pharmacy creams for like 5 years, what if it isn't a stubborn infection at all?
Yeah, what if it's actually your own immune system just slowly erasing your anatomy?
Exactly. I mean, welcome to the deep dive. Our mission today is to really unpack this widespread medical mix-up, and it's one that causes years, sometimes decades, of just silent frustration for so many people.
Oh, absolutely decades for some patients.
Right. We are talking about the frequent misdiagnosis of a chronic skin condition called lichen sclerosus.
Or LS, as it's often abbreviated.
Right, LS. And it constantly gets mistakenly labeled as simple recurrent vaginal candidiasis, which most of you probably just know as thrush.
And to really get to the bottom of this diagnostic trap, we're pulling from a pretty comprehensive stack of sources today.
We've got a lot of data.
We do. We are synthesizing clinical guidelines, including protocols from BHH, that's the British Association for Sexual Health and HIV. We also have guidelines from the British Association of Dermatologists, a bunch of patient advocacy resources, and some honestly very revealing primary care survey data.
Yeah, the survey data blew my mind. But, this matters to you listening, whether you're navigating your own health or maybe you're advocating for a partner or a child.
Yeah, it affects children too, which surprises a lot of people.
Well, we'll definitely get into that. Or even if you're just, fascinated by the blind spots in modern medicine, because this is a huge one.
It really is.
Imagine you have this persistent water stain on your living room ceiling, right? It's annoying. So you get some of that stain blocking primer, you paint over it, and it looks totally fine.
Until it doesn't.
Right. A few months later, the stain is back. So you paint it again. And you do this for years. But you are completely ignoring the slow leak in the pipe behind the drywall.
That is a perfect analogy. Because treating the symptom without examining the underlying architecture, you're eventually going to face permanent structural damage.
Exactly. And that dynamic is exactly what's happening in clinics everywhere. But I think to understand the misdiagnosis, we first have to understand the default label, right? We have to look at vaginal thrush.
Yeah, we have to start with the usual suspects. So thrush is fundamentally an ecological issue.
An ecosystem imbalance.
Right. We all have millions of microbes living in and on our bodies, forming a balanced microbiome. And within the vaginal ecosystem, you have these dominant friendly bacteria like lactobacilli that keep the pH slightly acidic.
Which is a good thing.
It's a great thing. It's protective. But you also have a family of yeast called Candida, just kind of living quietly in the background.
They're just chilling there.
Exactly.
Yeah.
And about, I'd say 85 to 90% of thrush cases, the specific yeast is Candida albicans. Now, when the ecosystem is healthy, your immune system and those friendly bacteria keep the yeast entirely in check. It's not a problem.
But I'm assuming that delicate balance is, incredibly easy to disrupt.
Oh, the triggers are everywhere.
Yeah.
If you take a course of broad-spectrum antibiotics for, say, a sinus infection.
Oh, right, because the medication doesn't know the difference.
Exactly. It doesn't distinguish between the bad bacteria in your sinuses and the good bacteria in your microbiome, so it just wipes out the lactobacilli.
Wow. So the protection is just gone.
Yeah. And without that acidic protection, the Candida yeast rapidly multiplies. It invades the superficial layers of the vaginal tissue.
And it's not just antibiotics, right?
No, not at all. The same overgrowth can happen when hormones fluctuate during pregnancy or in environments of poorly controlled diabetes.
Wait, diabetes? How does that connect to yeast?
Because yeast feeds on sugar. It feeds on the excess glucose in the tissues.
Oh, wow. I never even thought about that.
Yeah, it's all connected.
And the resulting symptoms from this overgrowth, they are universal alarm bells. We're talking intense, maddening itchiness, redness, soreness, and that hallmark thick white discharge.
Right, the medical literature almost universally describes it as looking like cottage cheese.
Which is such a vivid descriptor.
It gets the point across. And because of the localized inflammation, a patient might also experience, superficial pain during sex or like a burning sensation when passing urine.
So it's miserable. But the standard medical response is pretty straightforward, right? And usually highly effective.
Usually, yes. It's a quick course of an antifungal medication.
Like the ones you can just buy at the pharmacy.
Exactly.
Right.
Like an oral fluconazole pill or a topical clotrimazole cream. And these drugs work by basically targeting the cell walls of the fungus. They essentially punch holes in the yeast so it dies off.
That sounds brutal, but effective.
It is. And then it just allows the natural microbiome to recover.
Okay, but here's my pushback. If the sources note that up to 75% of women will experience at least one bout of thrush in their lifetime, I mean, 75% is a massive number.
It is huge.
So isn't it completely logical for a doctor's brain to immediately jump to a fungal infection when a patient complains of an itch? I mean, they're taught when you hear hoofbeats, think horses, not zebras, right?
You're absolutely right. It's basic pattern recognition.
Mm.
And there's a well-documented psychological phenomenon for this called diagnostic anchoring.
Diagnostic anchoring.
Yeah. When a clinician sees a set of common symptoms, they anchor to the highest probability diagnosis.
Mm.
And for the first or, even the second episode, anchoring on thrush is clinically sound. It makes sense.
Right, because it usually is thrush.
Exactly. The blind spot only emerges with the label recurrent.
Ah.
The BHH guidelines specifically define recurrent thrush as 4 or more episodes in a single calendar year.
Okay, so a patient keeps coming back complaining of the exact same intense itch, and the doctor just assumes they're dealing with, like, a mutant drug-resistant superuse.
Yeah.
They just keep handing out that antifungal primer to paint over the water stain.
That's exactly what happens. The reflex to simply re-prescribe is so strong. But the clinical guidelines explicitly warn against this autopilot approach.
They do?
Oh, yeah. They say when standard treatments fail repeatedly, or when a patient reports severe soreness without the hallmark itching.
Oh, wait, so the symptoms can change.
Right. Or when that classic white discharge isn't actually present upon examination, the probability shifts.
The horse becomes a zebra.
Exactly. The diagnostic anchor needs to be lifted because you are very likely looking at a completely different physiological process.
Which pulls us directly into the hidden mimic we're talking about today. The condition actually masquerading behind the itch is lichen sclerosus.
SLS.
And from what I read in the sources, this isn't an infection at all, is it?
Not even close. Lichen sclerosus is a chronic inflammatory skin disorder. And while the absolute, root cause is still being mapped out by researchers, the global consensus points heavily to it being an autoimmune condition.
So it's your own body.
Yes. Instead of an external fungus taking advantage of a disrupted microbiome, your own T cells.
Which are like the specialized soldiers of your immune system.
Exactly. Your internal soldiers become confused, and they begin aggressively attacking the healthy basal layer of the skin cells on the vulva and the perianal area.
The visual footprint of that autoimmune attack has to be entirely different from an infection, right? I mean, with thrush, you have that white cottage cheese discharge sitting on the surface of the skin.
Right, sitting on top.
But with LS, the skin itself physically changes color and texture. The sources describe the affected areas turning into pale, ivory white, thickened, or sometimes crinkled patches.
Yeah, the standard visual comparison in dermatology is that the skin begins to look like wrinkled cigarette paper or cellophane.
Cigarette paper. That really paints a picture of how fragile it gets.
It does. And the geographical distribution of those white patches is another major differentiator. LS frequently develops in a very specific figure of 8 pattern.
A figure of 8.
Yeah, it encompasses the vulva, and then it circles down to surround the anal area as well.
Oh, wow.
And because the tissue is under active attack, it causes profound pain with sexual intimacy, but also with bowel movements.
That sounds agonizing.
It is. And this can actually lead to severe withholding behaviors and constipation, particularly in pediatric patients.
Okay, wait. I need to stop you there
Yeah.
because the demographics in the research really surprised me. We culturally tend to associate vulval issues with adult reproductive age women.
We do. Wow.
But the sources state LS has a bimodal distribution.
Yes, bimodal.
So bimodal, does that mean the disease incidence peaks at 2 completely different, distinct stages of life?
That is correct. So we see a significant spike in postmenopausal women.
Which makes sense, hormonal changes and all that.
Right. It's likely linked to the drop in estrogen, which changes the skin environment, making it just more susceptible to that autoimmune trigger.
Okay.
But the other major peak occurs in prepubertal children.
Kids. That is just heartbreaking.
It is. It's not exclusively a condition of adulthood at all. And furthermore, it also affects men.
Right, I saw that. The male presentation involves the foreskin and the glands, or the tip of the penis. And it can sometimes cause the foreskin to scar and become so incredibly tight it cannot be retracted.
Which often requires surgical intervention, yeah.
But keeping our focus on the female anatomy for a second, the clinical data provides a golden rule for separation between these two conditions. Lichen sclerosus never affects the internal vaginal canal.
Never.
It is strictly a disease of the external keratinized skin.
Exactly. Whereas thrush, conversely, is primarily an internal vaginal flora issue that then spills outward to irritate the external vulva.
Okay, so let me put forward a hypothetical scenario for you.
Go for it.
A patient is experiencing intense itching and discomfort at home. They're trying to figure out what's wrong. They use a hand mirror to investigate, and they see a lot of white in the area. If thrush produces white discharge and LS creates white skin patches, a panicked patient in a poorly lit bathroom is almost certainly going to confuse the two.
Oh, 100%. It's a completely understandable mistake for a patient to make.
Right, I totally get why the patient thinks it's thrush. But clinically, in a bright examination room with professional lighting, how does a medical professional fail to tell the difference between a discharge sitting on top of the skin and actual tissue damage to the skin itself?
That is the big question. And the differentiation really comes down to understanding the mechanics of the damage. As you said, thrush is a surface-level irritation.
Right.
If a clinician simply wipes away the fungal discharge, the underlying skin will be red, angry, and inflamed, sure, but the cellular architecture is totally intact.
The building is still standing.
Exactly. But lichen sclerosus is an active demolition site. The T cells are destroying the actual structural proteins holding the skin together.
So the building blocks are dissolving.
Yes. The skin becomes alarmingly fragile. And a trained eye, looking at an LS flare-up, won't just see white patches. The sources point out specific structural failures you can look for.
Like what?
Well, you will often see purpura, which are tiny, bruise-like blood blisters under the skin.
Oh, from the bleeding.
Right. They're caused by the absolute slightest friction. Just wiping with toilet paper can cause them. And you will also see fissures, which are literal cracks or paper cuts in the weakened tissue.
Ouch.
Yeah. A simple yeast infection does not cause the skin to split open like that.
Okay, so if the clinical signs of an autoimmune attack and a fungal infection are that glaringly distinct upon inspection, I mean, we have to ask a really difficult question here.
I think I know where you're going.
Why are patients suffering for months or even years with the wrong label? How do you keep getting prescribed over-the-counter antifungals when your skin is visibly cracking open? I mean, the science is clear, so the failure must be in the human element of the healthcare system.
You've hit the nail on the head. And the survey data published in the British Journal of General Practice illuminates this systemic failure perfectly.
I couldn't believe those numbers.
When they surveyed healthcare professionals working in primary care, and keep in mind, these are the very people who serve as the front door to the medical system.
The gatekeepers.
Right. They found that 37.7% had never participated in any specific learning regarding vulval skin disease.
Over a third of primary care providers have zero formal training on this. Zero.
Zero. And the providers themselves are acutely aware of the deficit. An overwhelming 92.6% of the surveyed professionals admitted they felt ill-equipped and needed more education on diagnosing vulval conditions.
That is staggering.
It is. But historically, dermatology curricula focus heavily on visible areas like the face, arms, and back.
The stuff everyone sees.
Right. And then gynecological training focuses heavily on internal reproductive organs and childbirth. So the external vulval skin just falls into this neglected no man's land between the two specialties.
It's an anatomical blind spot in the curriculum.
Exactly. And that structural gap in medical school translates to a massive real-world problem in the clinic.
Yeah.
But it's also compounded by the social stigma of the symptoms.
Right, the embarrassment factor.
Huge embarrassment factor. Vulval issues cause intense shame for a lot of people. So a patient might wait until the very end of a rushed 10-minute appointment to even mention an itch.
The classic doorknob confession.
Yes. And the doctor, who's dealing with time pressure and genuinely trying to respect the patient's modesty, might just write a prescription based entirely on a verbal description.
Without ever looking.
Without looking.
Yeah.
The medical term for that is empirical treatment. It is the practice of making an educated guess and prescribing medication based on the most statistically likely cause.
I look at that practice and I really have to push back. I mean, imagine going to your general practitioner with a severe chronic cough that produces blood. If they just kept prescribing you throat lozenges for 3 years over the phone without ever once listening to your lungs or ordering an x-ray, we would call that malpractice.
We absolutely would.
So at a certain point, we have to ask if this is just an innocent lack of training or if this diagnostic anchoring is fueled by a systemic tendency to dismiss or minimize female pain.
Look, the sociology of medicine certainly plays a role here. Pain reported by women, particularly pelvic or vulval pain, has a very long documented history of being normalized or just attributed to anxiety.
It's all in your head.
Right. But to be fair to the practitioners, we must also factor in the genuine difficulty of symptom overlap.
True.
Lichen sclerosus does not exist in a vacuum. A patient might have eczema, psoriasis, maybe allergic contact dermatitis from a new body wash, or a localized nerve issue.
So many variables.
And every single one of those conditions sets off the exact same initial alarm bells: itch and pain.
They all look like horses at first glance.
Precisely. The critical failure of the system is not the initial misdiagnosis. An empirical prescription for thrush on a first visit is standard acceptable practice.
Right, try the easy fix first.
The failure is the refusal to pivot when the data changes.
Yes.
The guidelines strictly mandate that persistent doubt, an atypical visual appearance, or a poor response to a standard antifungal requires a complete physical reassessment. You cannot continue treating a ghost infection. You must actually look at the skin.
Because identifying the correct underlying condition isn't just like an academic exercise in getting the right Latin name on a chart.
No, not at all.
Because the biological mechanisms of these two diseases are totally different, so the long-term consequences of leaving them untreated are diametrically opposed.
They are. The stakes escalate dramatically with LS. Look, untreated candidiasis is agonizing, and it severely impacts a person's quality of life, but it ultimately remains a superficial issue.
Right.
Once the microbiome is restored and the fungus is cleared, that inflamed tissue fully recovers. It is entirely reversible.
But untreated lichen sclerosus.
Untreated lichen sclerosus leads to irreversible architectural loss.
The clinical descriptions and the sources of that architectural loss are just sobering. I mean, the chronic, unchecked autoimmune inflammation essentially melts the anatomy.
Melts is a harsh word, but medically accurate in terms of resorption, yeah.
Right. The labia minora, the inner lips, can completely resorb into the surrounding tissue or fuse together.
They literally disappear.
And the protective hood over the clitoris can scar and seal shut. It buries the clitoris entirely, which traps bodily secretions and causes immense pain.
It's devastating. And we also frequently see the entrance to the vagina shrink and lose its elasticity entirely.
The term I kept seeing in the guidelines was introital stenosis.
Yeah, introital stenosis. That is the medical term for the narrowing of the vaginal opening.
Right.
And when the tissue loses its stretch and the opening restricts like that, penetrative sex, or even the use of tampons, becomes physically impossible.
Because it's just terrible.
It tears, it bleeds, it is agonizing. It is a profound loss of physical function. But beyond the physical scarring, there's also a very real cellular danger.
The cancer risk.
Yes. The constant cycle of inflammation, tissue damage, and rapid repair creates a really unstable environment for the cells. And this instability gives lichen sclerosus a small but very real risk of developing into squamous cell carcinoma.
Which is a specific type of vulval cancer.
Yes.
Now, the sources place that cancer risk at roughly under 5%, which sounds low. It's a small minority of cases. But when you were talking about entirely preventable cancer, 5% is a massive reason to get the diagnosis right.
Absolutely.
And getting it right requires a complete paradigm shift in the treatment approach. If thrush requires, a 3-day antifungal cream from the drugstore, Ellis requires bringing out the heavy artillery.
It does. The treatment protocol hinges on ultra-potent topical steroids.
Ultra-potent?
Yes. The frontline medication recommended globally is clobetasol propionate. Right. And I need to stress, this is not a mild hydrocortisone you buy at the pharmacy for a mosquito bite.
Right, the 1% stuff.
Exactly. This is a class 1 ultra-potent corticosteroid. And the application relies on very precise dosing.
Because it's so strong.
Right. Clinicians teach patients to use what's called a fingertip unit.
I saw a diagram of this. It's the specific amount of ointment squeezed from the tip of an adult finger down to that first joint crease.
Correct. And that ensures enough medication is applied to the area to actually be effective without overwhelming the systemic bloodstream.
Because you don't want it absorbing everywhere.
Exactly.
And the regimen is intense. I mean, a patient typically applies that fingertip unit every single day for a month. Then they step down to every other day, and eventually tapering to a lifelong maintenance dose of maybe once or twice a week.
For the rest of their life, yes.
It reminds me of dental hygiene. You don't brush your teeth for a week and declare your mouth cured of plaque forever, right?
Yeah, that's a great way to look at it.
Managing LS is a lifelong routine to suppress the disease and prevent structural decay.
Yeah.
But I'm looking at this protocol, and it contradicts everything we are generally taught about steroid creams.
Ah, you are referring to the side effect of skin thinning.
Yes.
Yeah.
Because the medical term used in the sources is atrophic.
Atrophic, yes.
Right. If skin is atrophic, it means it is thinning, losing its structural integrity, basically wasting away.
Yeah.
And we are constantly warned not to use strong steroids for too long on conditions like eczema because the steroid will cause the skin to thin out.
That is the standard warning, yes.
But lichen sclerosus already turns the skin into fragile, tearing, atrophic cigarette paper.
It does.
So isn't putting an ultra-potent steroid onto already melting skin incredibly dangerous? I mean, shouldn't it just destroy it completely?
On the surface, it sounds counterintuitive. It perhaps even sounds reckless. But this brings us to a really fascinating paradox in dermatological pharmacology.
Okay, lay it on me.
The rule that steroids thin the skin absolutely applies to healthy, normal tissue. When you apply clobazole to healthy skin, it inhibits the production of collagen, and that causes atrophy.
Makes sense.
But skin experiencing an active lichen sclerosus flare-up is not normal skin. It is a war zone.
Right, the T cells are actively carpet bombing the tissue.
Exactly. So the medication's primary mechanism of action here is immunosuppression.
Oh, I see.
The ultra-potent steroid penetrates the skin, and it shuts down the local production of inflammatory cytokines. It literally forcibly stops the T cells from attacking the tissue.
So it's like a ceasefire.
Yes. By halting the autoimmune demolition, the steroid removes the destructive force. And this allows the skin's natural healing mechanisms to finally, catch up.
So the steroid doesn't thin the LS skin, it actually saves it.
That's the paradoxical truth. Applying the ultra-potent steroid actually prevents the skin from thinning and scarring further. And over time, with faithful maintenance therapy, the skin can actually regain some of its normal elasticity and texture.
That's incredible.
It is. And by keeping that chronic inflammation permanently switched off, the steroid therapy stabilizes the cellular environment, which is what drastically lowers that long-term risk of developing squamous cell carcinoma.
The very mechanism that degrades healthy skin is the only mechanism strong enough to halt the degradation in diseased skin. That is just an incredible biological nuance.
It really is beautifully complex.
And it perfectly illustrates why an accurate diagnosis is paramount. Because think about it. If a doctor misdiagnoses a fungal infection as LS,
You're tapping.
and they put an ultra-potent steroid on thrush, they will suppress the local immune system.
And the immune system is the only thing keeping the yeast in check.
Oh, no.
Yeah, but suppress it with a strong steroid, and the candida fungus will multiply uncontrollably. You will turn a mild thrush infection into a severe, agonizing, rampant overgrowth.
So the treatments are entirely incompatible.
100%.
Well, as we pull all these threads together, the core takeaway for you listening is to recognize when a symptom is actually a warning siren. A persistent, recurrent itch that ignores standard treatment is a red flag for a totally different underlying mechanism.
Yes.
The biological gulf between a localized fungal infection and a chronic autoimmune disease is vast. I mean, one is a temporary ecosystem imbalance, the other is your immune system systematically dismantling your architecture.
Exactly. And the goal of discussing this data is patient empowerment.
Right?
It gives you the vocabulary to look a provider in the eye and say, this empirical thrush treatment is not working. We need to rule out structural conditions like lichen sclerosus. Demanding a physical examination when the easy answers fail is really how you protect your anatomy and preserve your quality of life.
Absolutely. And to close out this deep dive, I want to leave you with a final concept buried in the research that honestly completely reframes how we view this disease.
The systemic connection.
Yes. Throughout our conversation, we have treated LS as an isolated skin condition, right? Confined to a specific geographic area of body.
Mostly, yes.
But the sources highlight an intriguing mechanism. While the definitive trigger for LS remains elusive, researchers have identified that a large percentage of patients with the condition produce autoantibodies that specifically target a protein called extracellular matrix protein 1, ECM1. And from what I understand, it basically serves as a biological glue.
It does. It regulates collagen and helps hold the layers of the skin together. So when autoantibodies attack ECM1, the glue dissolves, leading to that crinkled, fragile skin we see in LS.
But the immune system's confusion rarely starts at one localized protein, does it?
Unfortunately, no.
The data demonstrates that lichen sclerosus frequently clusters with other systemic autoimmune conditions.
Yes, it travels in packs.
Patients with LS have a statistically higher incidence of developing autoimmune thyroid disease, where the body attacks the thyroid gland. They are more likely to develop vitiligo, where the immune system attacks pigment cells, or alopecia, where it targets hair follicles.
It really reveals a broader systemic dysregulation. The immune system hasn't just made a localized error. it has developed a generalized tendency to misidentify the self as a threat.
And I really want you to consider the implications of that systemic link. What if a diagnosis of recurrent thrush isn't just a frustrating clinical error?
Right.
What if it is a profound missed opportunity for early intervention? Those subtle early skin changes in the vulva might not just be a localized rash. They could be the body's check engine light flashing on the
I
dashboard.
love that.
They could be the very first early warning system indicating that a broader systemic autoimmune shift is occurring. And we completely miss that warning because it is just easier to prescribe a pharmacy cream over the phone, anchoring to the most common label, and painting over the water stain while the pipes literally burst.
It's a sobering thought.
It is. Just something to keep in mind the next time you, or someone you advocate for, is handed the exact same old prescription for a problem that simply refuses to fade away.